Thank you. So yeah, I was not quite expecting to have pictures of me with more hair at the beginning of this, but thank you for Dr. Jones for bringing that. So first, my disclosure / who am I and where do I get my funding for my salary support basically from. So I have, like many here, wear many hats. So even though I went into emergency medicine at Duke, emergency medicine is in the Department of Surgery. So even though Dr. Jones tried to get me to go into surgery, I did not. I ended up a professor of surgery anyway. I also have an appointment to Department of Mechanical Engineering, where I run a research lab for robotics and data science for acute care. And clinically, I work in Duke University Hospital, but today I'll be speaking as the Deputy Human System Risk Manager at NASA, as in my NASA role. And so what does that mean, briefly? So in NASA, as an engineering organization, the human isn't a payload. It is a part of the system, the same as the avionics, as the structures, as the life support system. So the human is only as useful in the goals to accomplish the mission. So that kind of leads to the context of we'll get into later. But so for numbers, to update you from 10 years ago when we gave this last talk. So 10 years ago, we still had a space shuttle, and there was a space shuttle, and the Soyuz got you to and from the space station, which at that point was about 12 years old. And at that time, about 450 people had gone into space, US and Russian and all other nationalities. And that was the data we were operating from. So now, 10 years later, the space station has been in operation for 22 years. There's a couple more modules added to it. I no longer have a space shuttle. I do have a commercial program that gets people to and from Florida back to the space station, and still the good old Soyuz. And about now 600 total people have gone into space, and that includes 9-year-olds like William Shatner, and on that same flight in Blue Origin, I think it was a 19, 20-year-old, and everywhere in between, men, women. And then, so that's the entire set of data I have to inform what happens in space, is those 600 people that went anywhere from 3 minutes to a year, and everywhere in between. For context, that 40,000 that was the number of people that acquired over a couple months for J&J to get the EUA for their vaccine, right? So wildly different kind of magnitudes into the data I have to support these things. And so what I do and what we do, and saying NASA as an engineering organization, the human as a system, is my job and the job of the Human Health and Performance Group, which includes the flight surgeons and the researchers for human health and performance, is to provide a crew that is fit for duty when the mission calls. So I don't need a healthy person. I need a person who's able to do the mission objectives we put out there to do it. So if they are healthy, but their right pinky doesn't work, but they need their whole hand in an EVA glove to turn a knob, they are the same as if they are not functional. And so that's the metrics we use for success in human health and performance, and that's what we go to, right? So the other way to think about this is I'm gonna make a lot of generalities. In clinical medicine, mostly we're having unhealthy people to do more healthy things. Space medicine, kind of similar to all the performance kind of medicine things, is I have very healthy people doing unhealthy things, and I have to keep them healthy and able to perform while doing it. So it's a little bit of a change of the paradigm of how we're approaching these things. So Colonel Ford was very thorough, and so I won't repeat a lot of what she had said. And so going from the Mercury program to now, we have this increase in volume and length of time and amount of people who can go, and the demographics and type of people who are going, right? So it was generally 30 to 45-year-old fighter pilots who were going on those early Mercury stages. Now it's whoever shows up and buys a ticket. At NASA, I'm mostly concerned of selected astronauts who are going, but we also have to keep in mind that now on the space station, I have unselected people who are coming to the space station and interacting with my crew. So all that has to come into play, right? If there is a person who has a medical event on the space station because they are a commercial participant, it's very unlikely that the NASA crew member is gonna say, well, no, you can't open my epi, right? Like there's gonna be an exchange of goods and stuff to keep the mission operating. And this is the progression. And what we're going toward and the strategizing and getting forward to is how to live and operate on these 3-year missions to Mars, which is the ultimate goal of the US space program right now. And so some of the jargon you'll hear when you read about it in the news and stuff like that is there are multiple what we call programs beyond the space station to get to Moon and Mars. So Gateway is the vehicle that is going to be transiting and living in orbit around the moon or on the way, which is kind of a mini space station that transits. Orion is the way to get to and from the ground to the Gateway or the other commercial programs. And then Artemis encompasses all of these things. Anything that's supposed to get to and from the moon is considered Artemis. And so it's a combination of many programs that are doing these things. But you'll hear things like HLS or Gateway or thing, but if it involves moon, it is under this umbrella of Artemis, which is how to live and work on the moon in preparation for how to live and work on Mars. Right, and so with the ultimate question of what about Mars, and why was Mars this, in the medical clinical world, the different from what we've been doing before? One, so what does 3 years mean? So think when you're in clinic or something like that. Previously been working at a 6-month time scale, right, for the space station, which you can come back, and it's also about 6 months. So if you have someone post-op in a clinic or something, and they say, how many times do I have to see you in the next 6 months? You have a pretty good answer on that, right? What their time course and their clinical course over the next 6 months. Then they say, okay, how many times do I have to see you in the next 3 years? That is a much less certain outcome, right? So your certainty about what's gonna occur is different. And in space, think of it as an industrial environment, right? You're doing high-risk activities, lots of mass, lots of momentum, causing injury. There's different nutrition requirements and all these things. So your 3-year trajectory is less known, and I can't come back. And so the questions are kind of certain around, I can send the healthiest people possible, which is what we do, but that delta between what the outcome is at 6 months is different than at 3 years, right? And I have to decide 5 years ahead of time how many Tylenol I'm bringing, right, at that level. And so I have to plan all that out before I know who the crew are, before I know their medical history, and I have to be available to make them able to do the mission objectives in that time. And here's the evidence base, right? So that dot on the right is the entirety of human experience, clinical or otherwise, right? And now I'm saying, well, we can operate all the way on Mars. And so I don't have as big of an evidence base to support that. And so when I say spaceflight, what makes spaceflight different than Everest or other extreme environments? And so NASA, we've defined these 5 hazards of human spaceflight, which will change based on your objective, right? So altered gravity, we talked about, the space radiation environment, isolation and confinement, which contributes to a lot of this, the hostile, the closed environment, I don't have much space, and the distance from Earth, which contributes to how often I can get a clinician to real-time give feedback to maybe someone not trained in that specific procedure. And all these things drive what these risks of spaceflight are. And the further you get from Earth, we're talking about you need progressive Earth independence, right? When I use the phrase, I was just in the first half of the AI session before this, and I heard the word autonomous used several times. Almost everyone meant something different by that phrase, even though they all used it. And we have this thing that happens at NASA and larger organizations where the concept of you get a lot of smart people in a room together, that is great, and good things can happen, but often people will leave that room thinking different things. For the example I come up with in surgery, right, or even clinical medicine, the word bipolar. When you guys use it, it means something very different when the psychiatrists use it, but it's the same word, right? And so if you're saying, well, I need money for bipolar research, that means 2 totally different buckets of money or NIH institutes you're gonna go to get to that. And so that happens a lot at places like NASA where we'll say things like risk and test and danger or hazard. Those have different meanings, right? And an engineer, so in a clinical world, just because we all kind of come up with that stats basis, right? A 5% chance of this happening to the patient in front of me. If I'm making a clinical decision right in front of me, a 5% chance basically means that's not gonna happen. I don't need to consider it. You go to an engineer and say there's a 5% chance this is gonna happen during your mission, that engineer says, so that's definitely gonna happen during this mission, and I have to plan on that happening. And so even 5% means 2 different things, and it's the same thing. And so Earth independence is, now I gotta go, like there's, that 20 minutes is how long it takes for a question to be asked, to be answered, right? Imagine if you were talking to your scrub nurse or and asking a question, and it took 20 minutes to get a response, right? That's just not a very conducive and efficient way of doing communication. And this is also the medical, again, I'm not sending healthy people. The goal of sending people to Mars isn't to keep people healthy at Mars, it's to accomplish objectives at Mars, right? And so the medical system is part of the entire system. If I'm gonna bring a Da Vinci system, right, that means I can't bring a rover. And so things to think about in terms of the cost trade, in terms of the whole objectives of the system. And so the way we think about it at NASA as part of a system is, I can decrease my medical risk the more stuff I bring, right? More stuff or more people. But then that increases the non-medical risk, right? I will bring less water because I brought more Tylenol. And so you have to think about it in those trades, and we're trying to find the minimum of risk that gets the most out of it. And so these slides, the next one, are like almost all government slides. There's more data in them than there is stuff I can talk about, and I'm not going to talk about it, but I do encourage you to take pictures because this is another way for me to deliver data to the relevant communities. And so these are things that have happened in spaceflight. In those 600 people over the last 22, or actually 50 years, includes all of US spaceflight, right? Including Mir too. So as you notice, in again these 6 months and a couple 1 years in there, the surgical pathology in here is not high. It's not high acuity because we have 6 months. We make people as healthy as possible right before they start. And so this is stuff that has happened within the in-flight mission. So there's a fair amount of stuff, but again, all kind of treatable and has been treated. Enough that the only kind of impacts so far to human spaceflight have been, you can't do an EVA today, it'll take a couple weeks, or you need extra Tylenol, or you have to self-cath for a urinary retention and stuff like that. So what about between flights, right? So if I take those same population and say from the time you launched to 3 years, what's happened in that time, right? So they're all just as healthy as they would have been. And so these are, now we're getting a little bit more surgical pathology, right? So the pancreatitis and hemorrhagic cysts and all these things have happened and treated, and they're all available to fly afterwards. But that was because they had the resources of the Houston area medical system to do it. So what do we have on ISS, right? Which is going to be, in going forward, that's going to be the boutique gourmet thing that we will not have access to in the future, right? Because the ISS is something I can continually replenish and resupply, and if I use some Tylenol, I can replace it the next flight. That will not be true on Mars. But we have ophthalmoscopes. I have an OCT for the eye stuff we're worried about. I have ultrasound. I have IV equipment. I have enough IV fluids. I don't carry blood products. I have live monitoring of 2 and 3 lead EKG. I can store and forward. I can send down the ultrasound images as soon as I take them, or video, lower quality video while they're doing the ultrasound. I can give real-time guidance about, oh no, go to the left or to the right. All that will not be available going forward. And so, again, more data. These are considered what we call the red risks for human spaceflight. And so these are things that a red risk in the human health and performance world doesn't mean you can't go. It just means these are the things that are the highest priority in research and development in Moon and Mars. And so to help it out, I said, these are the ones that have surgical pathology, so you can see with this group. And so, I think I have it in there. Yeah, so you're like, why is food in there? I think for this audience, I don't really need to explain why food and nutrition is potentially a surgical science-related thing, but right now, I do not have a food system that's adequate for a 3-year Mars mission. I don't have enough way to give people calories for 3 years if I want to do anything else other than feed them during that Mars mission. And so things that can kind of contribute is to the nutritional effects of different scientific projects or ideas about how to increase calories or reduce needs could come from kind of this community. And then we say accepting risk. At the end of the shuttle program, it was considered you had a 1 in 90 chance of having a loss of crew member. At the beginning of it, it was a 1 in 10, right? And so that was what we were prepared to accept as risk. And so you have to think of what's the numbers that you're able to, what are the adverse outcomes you're able to accept, and discuss them in the context that we can use them in. And remember that anything you come up with has to interface with the rest of our flight systems, right? So a robot that only does clinical work isn't going to be useful if it's only needed when it's clinical, right? If it can also manipulate satellites, that's helpful for us as well. All right. So the last, I can kind of be done now. I have a couple kind of more examples, but to keep on time, do you want me to stop now, or we can just do it? Okay. Okay, yeah, so in the Mir program, there was fires, there was toxic exposures that had upper respiratory effects and different things. There's a great book called Dragonfly, which you can read and read more about it. Immunology, the immune system is considered to be depressed. They're immune, I don't want to say compromised, but not as immune competent as you would expect them to be on Earth just because of reasons we don't understand yet. There's been near drownings because if you're in an EVA suit, you can't touch your face, and if the water bubble just is right over your nose and mouth, you can have like that 1 inch of water can hurt a toddler. Same as an astronaut if they cannot touch their face and there's no way to shake that water off, and we had near drownings. And SANS pathology, increased intracranial pressure is thought to maybe lead to long-term changes in the eyes. This is kind of an active area of research. And yeah, and there's been many incidences of urinary pathology that we don't quite understand if it's due to the medications that we're taking with us for different comfort things, or just because of the spaceflight environment. So one of the big bugaboos that we're thinking, like, is this going to lead to urinary sepsis on a 3-year mission if I can't do anything about it? And I will stop there and we can discuss more if there's questions at the end.